It's a kind of paradox at the most extreme end, where people are so unwell they're disconnected from reality. They think that they're fine, so won't go looking for help. So actually, a person asking for help kind of by definition means that actually on one level they're actually doing quite well.
Benji, welcome to Audible. We're here
Thank
to
you.
talk about your book. You don't have to be mad to work here, A Psychiatrist's Life. Let's start from the very beginning. What is a psychiatrist?
Well, yeah, people do get very confused, don't they, about the difference between a psychiatrist, a psychologist, a psychic. So psychiatrists are medical doctors who have to learn how to treat the body before moving on to the mind. But yeah, there's confusion even amongst our own colleagues. I remember I was once going to a conference in Dublin, and on the aeroplane there was that announcement, is there a doctor on board? And I went over to help. And there's someone already doing chest compressions on this body, and I was like, hi mate, can I help? I'm a doctor. And the guy looked me up and down and asked, what type of doctor? And I told him I was a psychiatrist, and he sort of went, right, well, I'm an emergency doctor, yeah, so maybe if I manage to restart his heart, then you can ask him about his childhood. Absolutely slammed me. But yeah, so people still don't really know what we actually do, which is one of the reasons I wrote the book.
And what sort of patients and kind of mental illness do psychiatrists really focus on treating?
Psychiatry, because mental health resources are so stretched, tends to deal with more kind of what you might consider like top shelf madness, I suppose. And I guess I wanted to give a voice to people with more serious mental illness, people, things like schizophrenia, those people for whom some cold water swimming and mindful colouring in probably won't do much.
And how do those patients present when they end up in contact with kind of an NHS psychiatry doctor? What level of illness are we talking?
It's a kind of paradox at the most extreme end, where people are so unwell they're disconnected from reality. They think that they're fine, so won't go looking for help. So actually, a person asking for help kind of by definition means that actually on one level they're actually doing quite well, in that they have that level of insight. Whereas the people that I see where I work as a kind of emergency psychiatrist, they're often brought in against their will by police or emergency services when things have gone very, very wrong, I suppose. Yeah.
Yeah. And so what is it like being the first point of call where someone who's very ill and doesn't want to be there, and you're the person that they talk to? What is that experience like for you?
It's okay. I do feel quite conflicted in my job. I went into psychiatry and into medicine wanting to help people, and yet the people that I'm trying to help, because they don't think they need it, kind of hate my guts. And I never imagined I'd spend my life just kind of sectioning people and putting them in hospital and making them take medicines they don't want to. You're just not very popular amongst your patients, really. If you look at my psychiatric hospital's Google reviews score, I've got 1.2, and there's some kind of alarming reviews on there. But yeah.
And you write in the book about how stretched the NHS is, in particular mental health services. So how do you go about deciding who gets that precious NHS bed?
Yeah, well, it's increasingly difficult because, there's all this chat, isn't there, that mental health is no different to a broken leg, and that there's parity of esteem between physical and mental health, but we've still not got there now. If you think that mental illness accounts for 28% of the country's disease burden, and yet just receives 13% of NHS funding, and that discrepancy you kind of really, really feel when you think in terms of beds alone. The number of psychiatric beds has gone down from 70,000 beds in the 1980s to less than 20,000 now. So that's because of austerity and also because of deinstitutionalisation, which was this move to treat people more in the community. But it means that getting a bed is harder than ever, and they're reserved only for the most unwell people. And I suppose at its most extreme, I always remember we're just constantly triaging and trying to think who needs it the most. And at its most extreme, I remember once when I started training, me and my boss at the time saw someone who was thinking of jumping out of their bedroom window, and my boss discharged her because she only lived on the second floor of a tower block. And I just never imagined when I started this profession that I'd be allocating care according to whether jumping from a certain floor flat would create a big enough splat.
Yeah. And you're right that there's different kind of medical models in different places in the world, but in the UK we favour, for instance, for schizophrenia or psychosis, like strong courses of anti-psychotics if someone's in a really bad state. How do you feel about that, knowing that there are other things going on in other countries?
You know, psychiatry is supposed to practice this biopsychosocial way of practicing, so looking at the biological, which is kind of drugs and chemicals, the psychological, which is like talking therapy, and the social, which is, I suppose, the world in which the person lives. Due to lack of time and thinking and resources, our model feels very bio at the moment, and I wouldn't mind if it worked, really, but it doesn't seem to be. You know, our patients hate the drugs because they have really grim side effect profiles and often they may say make voices quieter and dampen delusions, but they'll say in exchange you'll get diabetes and obesity and die 20 years younger. So it's kind of not, I understand why patients don't want to take them, you know. In Finland, there's something called open dialogue where the focus isn't so much on medication and more time and energy is invested into kind of supporting the person in the community and involving family and doing other non-pharmacological things. And they've had amazing outcomes in terms of reducing relapse and people getting back into employment. It almost seems too good to be true, and it is. It's been researched in this country to see if the results are applicable here. So I guess time will tell.
And you write about electric shock therapy, which, I don't think everyone knows still happens. So what is that and why is it used?
Well, yeah, I was very naive. When I first turned up and my consultant suggested we were going to give electroconvulsive therapy for someone, I thought she was joking. I didn't want to let on that my sole knowledge of electroconvulsive therapy at that point had come from the film One Flew Over a Cuckoo's Nest. And it has changed, like, nowadays people do get put to sleep first, they have a general anaesthetic. But again, it's still a very controversial and mysterious thing. I remember I asked my boss at the time, how does electroconvulsive therapy work? And she said to me, nobody knows. She said it was one of life's big mysteries, and she said it was a bit like putting a frozen computer on and off again. I thought, oh yeah, that highly scientific technique.
And there's a few stories in the book, one in particular actually, where there's a lot of luck involved in you helping this particular patient. So tell me a bit about that story and how much psychiatry does have to lean a bit on luck.
Yeah, I took a medical student with me to see a banker in their home who the GP had been concerned thought that they might be suicidal. But when we got there, the banker was saying, oh no, he was fine, it was just some sort of mix-up. And this sort of stuff does occasionally happen, you know, like the same name but wrong address or whatever, and something didn't feel quite right. But we did have loads of other patients to go and see, and so we were halfway out the door, and I realised I needed a wee, and asked if I could use his toilet, and he very reluctantly let me, and it was only on going into the bathroom did I see the rope hanging from like one of these steel girders in his sort of warehouse apartment. And I managed to admit him, and he was safe in the end. But that was down to luck as much as anything. It was kind of funny because the medical student afterwards was, when we were walking to our next home, he was saying, "Oh, nice move, pretending to use the bathroom so you could suss out the flat." And I kind of thought about like fibbing, so you might think I was more in control of this uncontrollable world than I really was. But then I worried that might set an unhelpful precedent with him like insisting on urinating in patients' bathrooms thereafter. But yeah, and that was just a big dollop of luck, to be honest.
Yeah. And parts of the book are definitely an uncomfortable read. I mean, most of it is a funny read, but also an uncomfortable read. So what was it like to live through?
I mean, being a psychiatrist is definitely not good for a person's mental health. Psychiatrists have notoriously bad mental health themselves. Again, early in my training, I asked my boss if we were having a supervision session, and I asked my boss if we could open the window to get some air in there, and she was like, oh, the windows, they don't open, up here to stop people jumping out of them. And I said to her, what, even in the psychiatrist's offices? She said, especially in the psychiatrist's offices. it's a kind of, psychiatrists do struggle to stay well, and that's why we're encouraged to have our own therapy, and I have done that. I was feeling like, in the context of my job, feeling very low and not really sleeping and quite anxious and having some quite dark thoughts. And I actually said to my therapist at the time, I said to him, "Do you think I am depressed?" And he said, "No, I think you're an NHS psychiatrist." Which I think probably explained it as much as anything, because then I went part-time and I'm much better now.
How was it to write about and open up your own kind of childhood in a book?
It was okay. I think I'd done a lot of the early work in therapy, really. A lot of the stuff that reflect the stuff that I guess I write about are sort of insights I think I've gleaned from therapy. And I suppose I find it quite cathartic to kind of, talk about those things, whereas the culture in my family hasn't always been to sort of verbalise those. Like, I suppose, for me, I think what I found difficult, I grew up in the remote countryside where my parents were both quite unhappy and would fight quite a lot. And often a lot of my childhood was just spent trying not to stop them from killing each other, basically. And yet, interestingly, when I told my mum I was having therapy, she said to me, "What could you possibly be talking about in therapy? You had an idyllic childhood." And so I suppose it was just about working through that, because it has been quite confusing, I suppose, having that message from my family, whereas the reality, I think, was a little bit different.
Yeah, and you mentioned that your therapist said, you're an NHS psychiatrist, but you write in the book that medical students who are more depressed are more likely to go into psychiatry. So do you think that's a similar thing? They're almost trying to fix themselves?
A little bit, yeah. I think there is that. There was that interesting study, yeah, that was wondering, why is it that psychiatrists are more... Because there used to be the case that there were like two groups of doctors that could retire 5 years earlier because of the stress, and they were war doctors and psychiatrists. And I suppose they were wondering, well, is it the job that's doing it, or are they inherently a bit more depressive in the beginning? And that study looked at the well-being of medical students and found that they were already more depressive, the ones wanting to go into psychiatry, the ones wanting to go into other medical specialities. And I think being around human misery probably doesn't help a lot either afterwards,
Yeah, definitely.
Yeah. But as I sometimes think, like, I suppose if the logic is, if you're going to end up in a psychiatric hospital one way or another, you may as well get paid for it. Yeah.
And what do you think causes severe mental illness? What, in your opinion, leads people to, schizophrenia or extreme psychosis or other severe mental illnesses?
Well, the jury's still out on all of that. Again, like, no one knows. It's very mysterious. But the theory goes that it's too much dopamine, which is a neurotransmitter in the brain. But then there are other interesting things, like, and that some people think there's a family link, and that there's, it's caused by city living, and that, cannabis increases your risk, and things like that.
And you write about poverty as well.
Poverty probably accounts for the majority of mental illness, I would say, yeah.
Yeah. Do you think it's caused by the poverty, or do you think it's the kind of the other model where that people think that mental illness means that you end up poor?
Yeah, I think, there's two. I think it's probably definitely more the former. Mental illness does tend to disproportionately cling to poverty, but it is certainly the case that also, if someone does get a serious mental illness, they inevitably seem to fall down the strata of society.
And we've talked about how the NHS is underfunded. So what are the differences if you were to go to a private psychiatrist or an emergency private psychiatry versus the NHS? What does money get you?
What I do find quite interesting is that whether you go to lots of things influence what diagnosis you're given. Like I say, they're not objective things. There's no blood test for depression. There's no head scan for schizophrenia. It's all very arbitrary and subjective. And one of the things that can influence what diagnosis you're given is whether you're seen in the private sector or the NHS sector. And I think quite an interesting, so slightly more desirable diagnoses might be given in the private sector. So I remember I saw someone once who'd got a diagnosis been given diagnosis of personality disorder, and I said to my boss, could it not be explained like more in terms of like ADHD? She said, oh, she's not posh enough. Like if she like could afford to pay for like a nice shiny Harley Street diagnosis, she might get ADHD, but like we just say it how it is in the NHS, and so she's got pure personality disorder. And another interesting thing that I think a study that I remember that sort of highlighted, I suppose, this phenomenon was there was a famous study in the 70s where actors presented at psychiatric hospitals, and they were all saying that they were hearing voices. That was the study. And then they were all admitted to psychiatric hospital and diagnosed with schizophrenia. They were all actors. They weren't actually unwell. They were all admitted and diagnosed with schizophrenia, apart from the one person who presented at a private hospital who got diagnosed with bipolar, because you get what you pay for.
It's kind of terrifying to have a completely different, I know a diagnosis technically is just words, but like that label can really cling to people, right?
Of course, and that's why I try to avoid using labels so much, because they can be very stigmatizing and often can harm as much, cause as much harm as the diagnosis itself. Something as stigmatized as, say, like schizophrenia. If you a lot of people, there's such negative associations with that the way that society will shun such people can be as harmful as the illness itself. So I generally try to avoid using such terms. And you also hear, as people are starting to say, phrases like ADHD is just so commonplace now, or OCD, or anxiety, or depression, whatever. I sometimes want to say to society just to kind of hold those ideas a little bit more lightly, because they're not quite as fixed as people seem to make out.
Yeah, definitely. And there's one thing that you write about schizophrenia, which involves the voices that people hear and whether they're inside your head or outside your head. So why is that a distinction that you make?
We all have an inner monologue inside our heads. We hear our own thoughts and everything, and that we would consider that's just entirely normal, or you might call them pseudo hallucinations sometimes. Whereas what we might call true auditory hallucinations, which you might get more in, say, like schizophrenia or bipolar, tend to be more external, so they sound like they're coming outside your head, like my voice does to you now. So I suppose ironically it's really the voices outside your head that you really want to worry about.
I thought it was a really interesting distinction and not a way that I'd sort of ever thought about it before.
Yeah.
And in writing this book, you've put the whole thing together and then you have to go and narrate the audiobook. So what was it like to narrate the audiobook?
It was fun. It was nice of my publishers to say they wanted me to do it. They said I had a nice sleepy voice, so I guess don't listen to it whilst driving or operating heavy machinery. The process of reading it aloud, it was a bit like a kind of like a verbal metal detector for me, an emotional metal detector, I suppose, because in the reading I would get to certain bits and they would make me quite tearful, which took me by surprise. And I suppose it kind of told me if I got to a bit and I felt my lips start to wobble, I'd realise, maybe there is still something, there,
And if there was, something about mental health that you could tell the public, the general public, something that you'd really like them to know, what would it be?
Well, I would like society to connect better with more serious mental illness. There are exaggerated links between schizophrenia and dangerousness, and most people with schizophrenia will never be violent and are more likely to be victims of violence. And actually things like alcohol and drug use are much bigger, predictors of violence than schizophrenia is. So, technically I'm safer in a psychiatric patient's home than I am at a psychiatrist's house party. And I think it would be quite helpful if society knew that.
Yeah, definitely. Well, Benji, the book is like a hard at times, but a really, really great read. Thanks. It's been great to chat to you and great to read the book.
Oh, thank you. You too. Thanks, Holly.